this and turn on live. Oh. All right, welcome everybody to our November coffee chats. We are recording, just like I said, we are recording this goes up on our website and on our forums. If you'd like to revisit a coffee chat or if you missed one, you're more than welcome to head to our website and join the discussion on the forums. And we do have that live transcript available. At the bottom on your menu bar, there's a CC, and that's how you can turn on the live transcript if you'd like that on. These are our agreements we go through before each meeting. We practice active and empathetic listening and sharing. We challenge the idea, not the person. We be both teachers and learners. Here we take space and make space. The stories stay and the lessons leave. We use I statements. One person speaks at a time, and we want to be here and present now. All right, we will do our check-in question. Let us know your name, where you're calling in, and what is your favorite Thanksgiving or holiday meal side dish. I can go first. I'm Laura Jackson. I am the Director of Community for PFCC Partners. I am calling in from Eugene, Oregon, and my favorite Thanksgiving side dish is cranberry sauce, and it has to be canned. I like the canned cranberry sauce. All right, so I'll go down my list here. Carlene.
Good morning, everyone. I'm Carlene Parrish. I'm calling from Irvine, California. And I think my favorite Thanksgiving side dish is always stuffing, no matter what kind of stuffing it is. It's my absolute favorite.
Nice, yeah. I do like, I'm very particular about my stuffing, but yes, that is a good one. Thank you. Kathy?
Good morning, everybody. I'm Kathy Salazar. I'm in Albuquerque, New Mexico. My favorite Thanksgiving dish is sweet potatoes.
Ooh, yum. That is also good. Good. I'm just going to make a list. Dion.
Hi, I'm Dion Stalling. I'm calling from St. Louis, Missouri. And my favorite dish is also sweet potatoes, but I like them candied.
Oh, yep. Thanks for joining us, Dion. Linda?
Hey, everyone. I'm Linda Starnes. I'm in Orlando, Florida. And is pumpkin pie a side dish?
Yes, absolutely.
Actually, I love everything at Thanksgiving,
Yeah.
but yeah.
Absolutely. I feel like Thanksgiving, it all goes.
It all goes.
Yep. Thank you. Susan.
Hi, I'm Susan Conforti. I'm calling from El Dorado Hills in Northern California, and I like every kind of pie they make.
Nice. All the pies. Thank you. Libby. She might still be tending.
I'm still. Hi, everybody. I'm Libby Hoy. I'm calling in from Long Beach, California, and so many to choose from, but I got to go with sweet potatoes.
Mm-hmm.
Sweet potatoes.
Yep, that's a good one. Thank you. Lindsay?
Hi, good morning, everyone. I'm Lindsay Galley. I'm located in Sacramento, California, and I think my favorite side dish is a classic green bean casserole with the crispy onions on top. It's just good.
Yep. I'd have to say that's my second favorite for sure. Thank you. Just check my, Kristen.
Good morning. I'm Chris Palaschek calling in from Virginia. I think my favorite dish would have to be stuffing.
Awesome. Thank you. And Emily.
I'm Emily Newberry. I'm calling in from Portland, Oregon, and I refuse to choose between candied sweet potatoes and pumpkin pie.
I love that pumpkin pie's become a side dish now. Linda started a trend. Love it.
Way to stand your ground, Emily.
Yep. All right, let me check. I think, did I miss anybody? I don't think I did. Well, thank you everyone for sharing your side dishes. And we'll go ahead and move on. And I'd like to introduce again Emily Newberry. She's calling in from Portland, Oregon, a fellow Oregonian over here. Emily has worked for social, economic, and political justice from the March on Washington in 1963 to helping end the denial of gender-confirming surgeries by the Center for Medicare and Medicaid Services in 2014. Emily initially became a patient partner at Kaiser Permanente Northwest with a desire to support person-centered care and the integrated care model Kaiser Permanente embodies. She is now the member, mentor, and partnership coordinator at Kaiser Permanente Northwest and the person and family-centered care team. Emily is also a member of the PFAnetwork. And I will go ahead and pass it over to you.
All right, thank you so much. I'm just so happy to be here. I love that you invite conversations. That's something I do both in my job at Kaiser Permanente and in my other career as a podcaster. So love this. So let's go to the next slide. So I'm hoping to really, I like to use my own experience, and I like to say, yeah, it's about me, but it's not really about me. It's really about starting a conversation. So using my own experiences to do that. And let's go to the next slide, please. So I'd like to start out just talking about what do we do in Kaiser Permanente Northwest to engage our members in improving care. And I want to emphasize that I'm here speaking my own experiences. I'm not an official spokesperson today for Kaiser Permanente, although my manager knows I'm here and she's fully supportive of it. So and I think we're not unique in that in Kaiser Permanente. We started out with advisory councils because that's the traditional easy thing to do. And of course, back in 2012, when PFCC started with us, the easiest thing to do is to find retired people. And usually, especially here in Oregon, they tend to be all white or mostly so. Not because anybody had any bad intentions about it, but that's the easiest thing to do when you're first starting something up like this that needs volunteers. We have 2 for our hospitals. When I say 1 medical office building, is because we cover everything from Eugene up till Southwest Washington. And down in Eugene, we don't have a hospital that's easily accessible to our members. So our advisory council is for the Eugene Chase Gardens medical office building. And we're using that to improve service down there and see if we can grow our members. We have 6 advisory councils that cover service areas like the cancer service line, mental health, the NICU, neonatal intensive care unit are examples. And one of the things we've been trying to do, of course, with our advisory councils is to diversify the membership of them. And one major step we took this last year was we started the Black Health Community Advisory Council, the BHCAC. And something that's unique about it is that it not only has Kaiser Permanente members on it, it has some Kaiser Permanente frontline staff and representatives from community organizations that are involved in Black health in the community in one way or another. And we are really delighted that they came up with the idea of starting the Black Center of Excellence, which is focusing on hiring more Black physicians and supporting them after they get hired. So there's recognizing that, yes, it's wonderful to hire staff, but in a place like Oregon, which has traditionally been vast majority of white people, or at least that's who's been mostly recognized and seen. If you're going to hire a Black physician, do they feel like they're supported after they get hired, and finding ways to do that. So we have traditionally had patient partners on medical office building care councils, which the oversight team for the building, they have representatives from all the different clinics and so forth. That got really interrupted during COVID because staff got sent here and there to fill in on, you know, emergency situations and things, but also because in Oregon, we have a regulatory commission called the Patient-Centered Primary Care Home Regulatory Agency. And they pretty much demanded that we have those patients in those care councils. But their view of what they were going to require us to do, and everybody in Oregon to do, is to dive deeper into the medical office building. How are you actually listening to the patient voice? So we're really looking toward what do we need to do next, including bringing people on board as e-advisors only, so they don't have to go through the full onboarding process as a patient partner. These are all just wonderful ideas right now. But those are other ways that we're looking forward toward. How do we diversify the voices that we're listening to? We embed patient partners in teams that have a limit. They're given, here's a job we need you to do. Here's an area we need improvement. Go in there, find solutions, and then you're done. The team goes away, and we have a cross section of staff and 2 or 3 patient partners on those. And before COVID, we did in-person co-design sessions where you really go do the human-centered design thing, really go into depth into the patient experience and then also the staff experience. And in 1 8-hour day, come up with workable solutions. So different than the embedded teams in that it was just something where we really think we can, if we work hard, we can find a good solution for in 1 day. And partly because we can't do the co-design sessions in person now, we came up with the listening sessions, where it's a truncated form of human-centered design. And we might get, by we, I mean the people on my team, will get sent a list of names and contact information for 40 or 50 or 100 patients who've had an experience with a similar issue where we want to make improvements. We'll call them if they're willing. We'll interview them on the phone about their experiences. And then for 6 to 8 people who have the time and are willing to, we'll set up a video call where they'll sit and the staff will listen mostly. It's what we call it, a listening session, where we have somebody interview them again in depth. Again, how do you find as diverse of a group of patient partners to be on those calls? And at the end of the call, we put together all the information from the phone calls and the listening session and send it to the staff to look what can we specifically do to improve things. Of course, we do e-advisor things. People might get an email with short question and answer kinds of things, or short questions about their experience on things, and just done by email. You don't have to go anywhere. We're intentional about storytelling. We actually have a workshop to teach people specific skills, especially because people are going to be in meetings where they're packed and you can't just go on and on about your stories. As interesting as it might be, it doesn't serve the role of finding solutions. So how do you tell a story about your experiences in healthcare in a way that helps the other person get a sense of what it was like to walk in your shoes and do it in 3 minutes or less? So a skill for when you're in a meeting. And then for those who are willing, we invite them to make videos, short videos that illustrate things like the guidelines that we train our staff on. What does it mean to really respect somebody when they show in the door? What are the little things you can do that either leaves a person feeling respected and welcomed, or that don't? So these videos can be shown at stand-up meetings and other things. So our view of them is it's a way of combining the intelligence of the head and the intelligence of the heart. Get a meeting started with a really good video, about somebody's experience, and now let's talk about how we're going to make changes. And then, occasionally the National Person and Family Centered Care, FKP, reaches out to patient partners in all the different regions to be on different councils and teams. So that's what we do right now in order to involve the patient voice. And let's go to the next slide, please. There's a variety of ways that we actually recruit people to become patient partners. We love to get recommendations from frontline medical staff and administrators and things like the office buildings. They're the ones, and usually it's the administration staff who will send us a list of people for a listening session, for example. And people who get recommended to us by that way have one of the highest rates of actual people actually ending up participating. We used to set up recruitment tables. We would literally go into a medical office building or a hospital with a table with a green tablecloth and our, KP logo and Person and Family Centered Care literature. And I don't know if you've ever seen those fruits and vegetables that you can use to exercise your hands, giving those away, offering those for free. They led to some really interesting conversations, but we were lucky if 2 to 10% of people actually would end up volunteering anyway, partly because it's hard to really give people the full story about what it means to volunteer, partly because people then get home and say, you know what, I don't really have time. And sometimes people just don't like saying no to your face. So they'll sign up, but then they don't come back. There's some word of mouth, people who hear about the program and contact us. And recently, especially over the last year and a half or 2 years, because we're trying to be really intentional about how do we find a group to increase the diversity of our patient partner pool, we have been using comments that people make on after visit surveys. So Preskini and CAPS surveys. First of all, because we believe that somebody is willing to take the time to actually not just give us a score of 3 or 4 or 5, but to say why they gave that number. They're already taking their personal time to help us. And so I go through and contact those folks. And the first thing I say is, thank you for doing that, because we really do use those comments to improve care. We actually have somebody in the Northwest who reads every single comment that people make on all of those surveys and make sure that they get sent to the clinic or the hospital where they apply. So people are just surprised to hear that. They're like, oh, you really listen. And I'm like, yeah, we really do. But we also hope that if people are willing to take the time to do that, that they might think about volunteering as patient partners. And I don't have access to, Epic and people's contact information and so forth, but I have colleagues who do because of their specific role in Kaiser Permanente. So I will tell them, for this purpose, only send me BIPOC and new immigrant people, or only send me women under age 30 or whatever like that. So because I'm not going to contact all the other people, so don't bother sending me their information. And depending on the purpose, we will call people who fit the need of building a more diverse voice for that specific purpose. The Black Health Community Advisory Council was one example. We were, of course, very intentional about that. So those are ways that we're trying to. We're open to new ideas about how to find people and how to make it easy for them to participate. Let's go to the next slide, please. So we feel really happy that, especially using the comments, but from other reasons, from help from our frontline staff as well, our patient partner pool has gone from 6% to 20% diversity in ethnic and racial backgrounds. And we're looking for more than that even. We're going to try and increase our participation of people on different income levels. We think that's really important. because regardless of your ethnic and racial background, there's some things about not having a lot of money and resources that has a direct effect on your ability to get good health care. Also, for those of you who aren't familiar, Kaiser Permanente is an integrated healthcare system. That means everything from primary care to hospital care to your insurance. So if you're coming in as a Kaiser Permanente member, that means you have Kaiser Permanente health insurance. It might be from your employer. It might be through Medicaid. In Oregon, that's called the Oregon Health Plan, or it could be, Obamacare. Isn't just buying it as an individual. So we want to have people who come in to us all through all those ways, and we definitely need more people under 30. That's one of the challenges. And for people who are under 30, quite frankly, oftentimes they're even a two-parent family with 2.5 jobs, right? And children. And how do you involve them in a way that makes it possible for them to be really active? So working with challenges like that. Let's go to the next slide. Alyssa, first of all, let's see, does anybody have any questions or thoughts about that so far? Okay, next slide. So one of the forms of diversity challenges that I'm really interested in, and in addition to hearing your thoughts on diversifying patient partner pools in general, we can see that slowly the restrictions on COVID are lifting. More and more people are able to gather, in person when they couldn't before. So we're looking at, okay, what are we going to do about hybrid meetings? And we always used to, like an advisory council in the past, there might be one person who couldn't make it in person and showed up. And we would do the best we could, to make sure that they got heard and all like that. But if you're going to have situations where a third of the people just regularly are not able to attend in person because of whatever their personal circumstances are, how do you make sure that they feel really welcome in the room? And one idea I've heard from someone else is, all right, the people who are in the room, number one, everybody should be on a device, whether it's a smartphone or tablet or a laptop, so the people at home can see everybody's face, just as though it were all everybody were just calling in. And for the people who are in the room physically, rather than using the audio from their own device, to silence their own device, except for one of the laptops will be connected to one of those devices that sits in the middle of the table where it's got a speaker and a microphone in it. So it's like a physical way of trying to help those who are in the room feel like, yeah, I'm in the room with people, and if I want to, I can look and see their facial expressions and their body language more easily than I could when I was at home, which is what people really miss. But then the people who are at home on whatever their device is really can see what people who is talking and what they're saying in a more direct way than they could if it was just like one camera at the end of the table trying to keep track of all that stuff. So that's just one thought I have about making the hybrid meetings be such a character that everybody feels included and heard, and we're all a part of this group. And I mean, this is important, and probably for reasons we don't even know yet. I mean, there's, just the fact we can guess that if you're at home on a computer and majority of the other people in the room, you miss out on a lot of the body language and so forth. So this is one way of that everybody's on your screen overcomes that a little bit. But there's probably ways. Well, I can tell you one that I know of. What if you're somebody who's living with a disability, and your way of getting to the meeting would entail contacting, the public transit 3 days beforehand, and then they might get you to the meeting an hour and a half beforehand, and then it's, 45 minutes or an hour before they pick up you up afterwards. It's just like taking up half of your day or more. So you're not going to attend the meeting. We need to make sure that those folks all feel not just accommodated, but really welcome. And how do we do that? So that's kind of my way of sparking off this conversation about diversity in our patient partner pools and of really making voices feel invited. We know from experience that people from marginalized communities, one of the barriers to participation is experiences from the past where they have been devalued or dissed or discriminated against, and do they trust us as an organization that will really listen? And why should they volunteer if somewhere in their gut they really don't feel trusting? How do we overcome things like this? And I'm sort of interested in all of your thoughts on these things.
Thank you so much, Emily. So much great information and super interesting topic. So I am also interested in what folks think. So let us know. Feel free to come off chat and we can start the conversation.
Or type things in the chat. That's
Yep.
what you feel comfortable with.
So I'm going to start us off because I have so many questions. Thank you so much for sharing your perspective and the efforts that Kaiser's going to increase the diversity. I think this, is something that as an organization that helps health systems set up patient family advisory programs, not necessarily just PFACs, but it's an and for us, but also, we talked all the time about your PFAC really needs to reflect the population that you're serving. And then we sort of walked away and said, figure it out. And this, we were challenged in 2020, like so many others, to start to really live our mission and vision and values and not just, words on a website. And so I think what we've done is to really focus on inclusion. And I think you spoke to that when you started talking about all the different ways that people can get involved. I think that is a more inclusive approach than a singular, patient family advisory council. And I loved the ideas that you shared about your recruitment. The one I wanted to ask you about is the first one. So you mentioned getting referrals from your clinical staff or your administrative staff. And I really appreciate that. I wonder if you've ever seen from those referrals from your clinical staff, do you feel like the people that are coming to you through that avenue, sort of said yes because of that power dynamic between the clinician and the person? Or are they self-motivated to participate? I'm just curious what you've seen in using that strategy.
Okay. There's a wide variance there. So some of those are just the list of names of people who've had experience with a specific issue. So they have no idea. We're saying your physician said you might be interested, but this is the first they've heard of it, right?
Oh, okay.
But there are other times, like the Thriving Families service line regularly sends us the names and contact information from mothers. It's almost all mothers who've gone through a specific process in their care with the service line.
I see.
And they've already been sent surveys to fill out, and on the survey there's a place to click. Or would you be interested in considering other ways? So they already have a sense that they're going to be contacted, and they've had that e-advisor kind of experience with us. So there's that, and then occasionally, like a physician will just know somebody really well and happens to know and really very actively support person and family centered care, and will say, I think I don't really like the way you ask questions and give your opinions. you might be interested in this. And then, so the patient says yes, then the doctor will send us their information. So
Mhm.
that usually is a person who's already positively interested. Now, are they willing to go through the 12 or 15 hours it takes to get onboarded? Is a whole nother story, right? But at least they're
Sure.
positively, already positively inclined toward it. And then the people through comments, that we get a pretty good reaction. I want to say, I haven't done a close statistical analysis,
Mhm.
but I would say probably about 15 or 20% of the people we contact are positively motivated toward the idea of it. They don't all
Okay.
can all do it in the end,
Right.
but because it's like there's somebody who's already shown an interest by making the comments, so they're
Mhm.
more likely to be inclined to participate.
Sure. That
Does
makes
that
sense.
answer your question?
It does. It does. Thank you. Others?
So, this is a conversation with every group and every committee or work group or board that I sit on. And not all of them are healthcare related. They might be
Mhm.
disability related or some other such, but it's such a constant conversation. And so
Mhm.
I like being able to catch a new little nuance or idea and hear some of that from you, but I'm going to also bring up what tends to go hand in hand with this conversation, and it's the idea of compensation. And literally this week I was in 2 different meetings, and diversity of membership and compensation were in the same conversation. And I'm just curious, does that come up with you all in your process that you're going through and trying to consider other ways of having diverse members involved?
That is a long-term conversation.
I know, I'm sorry, it opens up a bit.
No, there's nothing wrong with bringing it up. It's really important. I believe, especially for some folks, and especially places where the Northwest region is a little bit more compact, say, than the Southern California region of KP, which people face much more bigger, travel times and things like that, even than we do. In the past, we've been able to do things like when our advisory councils were meeting in person, we would order a salad or a sandwich, depending, and you have a choice of which ones. So we meet early, everybody has a meal, and then we have the meeting. We've done thank you things at the end. We can legally do like giving somebody a gift card, and the amounts that we can do are limited, but we always, and I'm sure we're not the only ones, run up against things like the fear that now these folks are going to be treated as employees, and what complications does that bring up. So it's an ongoing conversation. There are some things we can do. If somebody's going to go to a national conference, we definitely pay their way completely, transportation, food, lodging, and everything. But right now we can't do what we would like to do. I'll put it that way.
And
it's an
again,
ongoing conversation. Yeah.
I was just curious because it just seems to be paired because because when there's always this skewed group of us who are like me, a little bit older, white, and a mom, woman, whatever, and that's skewing, and just trying to figure out ways so you don't have skewed voice in that capacity, as well as for research purposes. Same thing. It all kind of goes together. Thank you.
And we're hoping that the hybrid, being really good at the hybrid meetings, will expand the range of people who can participate. But we have to work really hard. I mean, we got some ideas about it, but when we actually do those hybrid meetings, we're gonna fall flat on our face many times, and we're gonna have to learn from those experiences.
Thank you.
That's technology for you, huh?
Yeah.
Yeah. Kathy?
What else?
Hi, this is a great conversation, and like Linda, her and I are on a lot of things we do together throughout the country, even though she's in Florida and I'm in New Mexico. And again, too, I run the Family to Family Healthcare Information Center for New Mexico with we're the Family Voices affiliate. Parent compensation is a huge, big deal. And it's really about cash. It's about money. You know, gift cards are great. Making sure that we feed them should be a non-starter if they're in person. We are making it an absolute priority in New Mexico to figure out how we use our federal grants. And we have several contracts going on right now that families that we invite for very specific workshop series or in-person workshops for several hours that we're able to provide, because in New Mexico, we're the 5th largest state, only 2 million people. And so if we want families to participate from in a in-person workshop, we need to provide them with a hotel room the night before, right? And we need to provide them with a stipend. And virtually they go through the 4 workshop series, and then we provide the stipend, possibly prorated on the fact that they might not have been able to attend all 4. So it's really, I think it's really important that as groups, hospitals, whatever, we're looking for that family voice, that self-advocate voice, that there has to be compensation in this. We can't keep asking people to give their expertise and be expected for it to be free. It's just not right. They are bringing lived experience to all of these, all of this participation, and their lived experience is valuable to making systems change.
Yeah.
So,
and I would add two things. One is here in the Northwest, Kaiser Permanente actually has a Center for Health Research, and they can get away with offering people stipends and things like that because they're research subjects, right? And it's a different part of the law. But the other thought I have is that to some extent, this quandary over compensating volunteers is partly a result of progressive politics. That states like Oregon and California in particular, I know because I've lived in both of them, do a good job of trying to protect people who have paid jobs. Are they getting paid properly? Are they getting overtime? Watching, are they being forced to work more than 40 hours and all that kind of thing? There are all the rules and regulations you have to follow, that the minute it looks like somebody might be an employee and not a volunteer to somebody up there in the regulatory world, it might turn out that they're okay, but it's complicated. Now somebody has to answer them, and there's research, and it just makes it more cumbersome for the organization trying to bring the volunteers in. And there's some people who have a responsibility to protect the organization in certain ways, have understandable concerns about, wait a minute, if we do this, look at all the problems and the expense it's going to cost, and like that. Now I have my own answer to that, right? But that's me. And I'm not responsible for that regulatory stuff, right? I don't have to worry about some regulator coming and giving me a hard time.
Right, but I think there's ways to do this. I think that honest conversations happen with those lived experience families that come to give their time, and the stipending them. Yes, anything over $600 has to be a 1099, and then they have to pay taxes on it, right? Some of it may affect, especially if they have small children and have access to Medicaid or access to SSI, might be an endangering. So those are honest conversations we have to have about not making the person an employee, but being able to have their expertise at the table and stipend them. And so we really, for me, it's a huge deal that we protect our families' benefits,
Yeah.
especially SSI and access to Medicaid if their child isn't already on a Medicaid waiver. Huge, big deals. And so you really do that by watching, you know, how much you're stipending, how many times they participate, those type of things. And also you don't want them to participate where they're the only voice. You want to have this ability to attract other voices. And so, you know, it's just a thought as you go forward, thinking about these things, that there are ways to not think of them as an employee and not endanger their benefits in any way.
I would love to see a conversation like this of people who've had positive experiences and be able to do that. Come and do a presentation. I would love to see that. I'll take that home.
Thank you, Kathy. And I saw Dion had her hand up.
Excuse me. I was listening. I promise I was.
Okay.
But I'm trying to get clarity
Yeah.
on what Emily actually needs. I was going to touch on what Kathy said, because when you start giving people money, let me say I'm a patient first, and then I am an executive director of a nonprofit that does not pay me a salary yet because I don't want to lose my Medicare benefits. I hear it's harder once you get off to get back on, and since my illness is lifelong, but the compensation piece is really a big thing, because you do have to be careful. If the family is on food stamps, I believe they have a guideline of what they have to have. And then also with the Social Security Administration, because here in Missouri, I'm not sure about other states, SSI is for people that probably have never worked, and they get SSI. SSID comes from the Social Security Administration, and you're paid based on what you paid into the system. Both of them do have income guidelines, and based on, there's a formulary or something. It's not even the same across the board, which is crazy. It should be no matter where you are. If you make this much, then it throws you into that. But I was also just trying to get clarity on what exactly your organization needs. I was listening, but I had questions why. I should have put it in the chat because I've forgotten now.
Okay. Well, for one thing, I can say, because we're a national healthcare organization, we have to deal with state rules that differ, right? Oregon's different than California, that's different than Georgia, and so forth. And I'm not an expert in this. I know because I've heard other people on our Kaiser Permanente national call talk about this. And I think some people in some of the PFAs in Southern California in particular have gotten away with providing help, like with transportation. Here in Oregon, somebody who's has a disability or is on OHP can get free transportation, but it's just a pain in the neck getting it, right? Because it's a van that goes around, and anyway. But yeah, I would just love to hear what other people have done that's made it successful in getting around those, not just the rules of the state government you're in, which aren't 100% applicable, but also how to have the conversation with those who have the responsibility for dealing with the regulations in your organization. So at Kaiser Permanente, we're all around everything, We've got people who have to deal with the legal stuff, with what if we get sued? Like, what if the regulators come at us because we're doing something a little bit different? How do we explain it in a way that we don't get in trouble? That's their whole world. And so I try to be, even though I have my opinions about things, I try to be understanding as I listen to their viewpoint about what the challenges are. And to understand they're trying to protect the organization, because if we run up legal costs for something we do unthinkingly, that takes money away from direct care.
So I think this is such an important conversation. I really, and we've been having this conversation for years, literally, right? But just two quick thoughts to add. One, Dion, going back to your question and your point, that what has been termed the benefits cliff is a very real risk to patient family partners and folks like yourself that are working in nonprofits. So the work of understanding what the benefit cliffs look like in each state, because like you said, they are different in every state, which is mind-boggling. And it adds complexity, I should say.
And I don't mean to interrupt you. It's different in every state, and it's different for every individual, because it depends on how much Social Security you get. They'll only let you, if I want to work, I can only make, I think, $1,200 a month, and it varies from, it could be $1,200 for me, and it could be $700 for you. And nobody can give me a formulary, not even Social Security Administration. They can't give you a formulary, and it changes from year to year.
Yeah.
Yep. I'm so sorry, first of all, that it is so complex for you and difficult. And I think there's a lot of work going on to try to understand this a little bit better. And I'd love to connect you with that. I know our friends at CHCS have done some work around this. Our PFAnetwork member, Naomi Williams, lives and breathes this because of her own situation as well. So would love to keep you connected, because I think this is going to be an evolving conversation. It's going to need to be an evolving conversation, because my second point that I wanted to just bring up is something that I heard from Desiree Collins Bradley, for those of you who know Des, years ago, that really flipped my thinking, because I didn't understand the relationship between compensation and diversity. So what Desiree said was volunteerism in and of itself is privilege. I didn't get that for a really long time. And there's this fine line between incentivizing people to participate, which I'm not really sure where that gets you. I think that gets to some of the concerns Emily raised from the organizational standpoint. You know, at what point do they become, you know, employees, and they're just coming to hear, tell us what we want to hear kind of thing, versus a partner who's really bringing that lived experience, as Kathy referenced. And so I think that's a really fine line that groups like us need to continue to wrestle with a little bit, because the answer is not clear. But we have found in the work that we do with LA County DHS that providing some stipends for a listening session, for you know, this, that, or the other thing, does remove barriers of participation for parts of our community in Los Angeles that otherwise wouldn't be able to participate. And so when you look at compensation through that lens of removing barriers to participation, the conversation shifts a little bit. And I think that's where organizations, Emily, are starting to push back on some of those regulatory, and I hope that we'll start to see, well, I think we've already started to see a little bit of a groundswell for hospitals and health systems to start to really wrestle with this, because if I do think there's a connection between compensation and removing barriers. And then the last thing I wanted to say, and I'll shut up, is some of the unique ways we work really hard to make sure that we don't compensate anybody over $600 annually. Even if it's for an annual commitment, we'll break it up into 2 different calendar years. And so that has worked. The other thing is with the gift cards, our understanding predominantly across the country is that a gift card to Target has to go towards your income, but a MasterCard cash card doesn't, for whatever reason. So no, I have that flip-flopped. If you give a cash card or something of that nature, then it has to go towards your income reporting. If you are giving a goods and service card, it does not. So I'm going to double check that. But anyway, those are kind of some of the things that we're trying to figure out in order to help people and help, avoid that benefits cliff.
Yeah.
And Naomi actually did a coffee chat on the benefits cliff a few months ago too. So that's something we can follow up with and send out so everyone can get some more information. Linda?
Sorry, I feel like we've kind of, Emily, I feel badly that we maybe moved it a little over off the line of where you headed with this conversation, but I did want to say I put in the chat the community of practice group that I was with this week is out of the genetics and rare conditions world, and it was all family partners, family leaders, whatever term you would like to use, and it was a very rich and robust conversation, just like this one, and the concern of, it's better to err on the side of providing compensation or asking if they would like to receive compensation than not, and have it, because the word incentive gets used, and that's an old word for all of this, in my opinion. How many people say, yeah, sure, I would love to go and be in research and have my blood drawn and do all that kind of stuff as an incentive activity. It's people do it because they care, they want to be involved, but yet it's also needs to be respected. So anyway, we all were coming down on the fact that even if a couple of people might get tinged by doing it, and it's an incentive for them so that they can get some money, I would far more weigh it on the side of giving compensation for the sake of that respect and need. And I know you're not on the research world, you're in the advisory capacity world. Now I'm going to the hybrid question, and the things that the groups that I've been in who have used the hybrid meetings now and have been doing it for a while, they are really good about building relationship as much as getting to the heart and meat of why you're getting together to discuss a certain issue or concern or challenge. But that if there is relationship building, so that those questions like what we just got through answering today are done both with the in-person and the hybrid group, to do those kinds of icebreaker kinds of questions, or check-ins that are relationship and trust building kinds of things, that goes a long way. And then also making sure everybody is using the same set of norms, like you all here at PFCC are so great about doing, is setting that norms standard for the group, whether you're in person or on the call in a hybrid fashion. Everybody follows the same norms. Yeah. And so anyway, but you're right. I think you're going to learn a lot the more you get into it. And but I think that hybrid option is very important for your diversity.
Yeah. And I agree with what you're saying about the building relationships. That's something we emphasize as we bring patient partners on board. There's at least 3 times during the onboarding process where we talk about collaboration guidelines. What does it look like? Be honest about what your experience is. Be curious about the other person's point of view. Assume everyone means well, even if they're doing something you disagree with, right? All those over and over again. Because if you want to embed something like that in your culture, you have to repeat it. Just saying it once doesn't do it. Because nobody can embed something unless they've had experience with it over and over again. Yeah, I really like that.
I like that thought, Linda. It's why I love these PFAnetwork meetings so much too, is because we all know each other, and even though we're all on these tiny little screens on the computer, we are connecting. So I like that. It's a good thought. Thank you. Lindsay?
Yeah, I know we're approaching the end of the hour, but Emily, we do pretty much all virtual stuff here at PFCC Partners because we're serving such a vast community. So I'd love to connect with you after this to give you some additional ideas on how to create those relationships virtually, and have some fun with it too. In our skills exchanges we use apps or websites, like one called Mentimeter, where you can build word clouds together, and people in the room can use that, and who are online can use that, and you can do polls. And I think one of the things that I've learned in having that interaction from the virtual audience, I guess, or participants, is getting them involved and engaged early in the conversation, no matter what it is. So, and Laura does a good job at this too, get everybody talking in the beginning, introductions, and, doing some quick polls up front. I think just some of those super interactive pieces. And we have some other ways where, we can do brainstorming virtually we use another app called Jamboard. So there's a lot of things out there that, people in the room and who are joining you online can do to make sure that everybody feels included. So I'll follow up with some of those and we can chat more.
Yes, I put my contact information into the chat.
Got it.
Anybody wants to reach out. And I would say another thing, it's like for every benefit, there can be a downside. Like at Kaiser Permanente, we're really strongly careful about protecting people's personal health information. And our systems are like really secure. You don't have these long strings of numbers and letters I have to enter just to check in, right?
Yep.
And I love that. I love that that's true, and it can get in the way too of really involving people. Like we use Microsoft Teams for all our meetings, and so we're somewhat limited in things like, I would love to see something like Mural or Jamboard used more often, and it's not as easy on Microsoft Teams.
Microsoft
so it's like
Teams
one of those trade-offs that just are like.
I hear you. Hear you.
Thank you. And Linda put in the chat also had a dedicated admin person watch the chat and the raised hands, which is, we do that too sometimes. I
often play that role in some of these meetings.
Well, thank you everyone for all the great input. Like Emily said, her email is there in the chat. Feel free to get in touch if you have any other ideas or questions. And we will be continuing this format for coffee chats in the new year. So, and we have the full year open and available for anyone that wants to come in, like Emily did today, and ask questions of the PFA network, share your resources, share your projects you're working on. And we'd be happy to have you. My email is going to be in the chat very soon. And you can email me and we can get you set up for a future coffee chat. Thank you, Emily, so much for coming today and sharing all your great information. And thank you, everybody, for joining us.
Thank you for the opportunity, and thank you for everybody's participation. I really appreciate it.
Thank you.
Absolutely. Happy Thanksgiving, everyone. We are deeply appreciative of the PFA network. So thank you.
Thank you.